Welcome, everyone, and thank you for joining us for today's webinar sponsored by Electrocore. We have a great presentation prepared for you today. Now, it is my pleasure to introduce our moderator, Dr. Mark Tagger. Dr. Tagger is one of the nation's leading healthcare communicators, the author of multiple books and online training courses, and a speaker at conferences throughout the world. He is able to concisely boil complicated concepts down to practical tips and techniques. Dr. Tagger is grounded in integrative, regenerative, and aesthetics medicine. Welcome, Dr. Tagger.
Thank you so much.
When you're ready.
Great. Excellent. Thank you. And we're excited to welcome you here today to this session on how to help your patients to a better brain through something called NVNS, non-invasive vagus nerve stimulation. This webinar is co-sponsored by the Vagus Nerve Society, and I'd encourage all of you to join. It is a multidisciplinary group that is global. It is a 501c3 nonprofit. It is essentially the repository for education and training on all things vagus, and that means implantables, non-implantable devices, nutraceuticals, lifestyle, anything that touches the vagus nerve. And it is a no-fee membership through this year. So you'll find that you'll see the QR code and please go ahead and join. These are our presenters. You see them live here. We've got an exciting presentation for you from Eric Liebler, Alison Yarnell, and Peter Stotz. I'm going to ask them to just go dark right now, and we will go ahead and let me make a few introductory remarks for those of you who didn't attend our first vagus nerve session. So today what we're going to do is go over the latest research and how the vagus nerve affects multiple organs and organ systems. We'll touch on the history of non-invasive vagus nerve stimulation and how it works. Very excitingly, we're going to look at, Eric Liebler is going to look at how the military is using NVNS to improve attention and reduce critical errors and fight fatigue. Then we'll go over to across the pond to the UK, where Dr. Yarnell will talk to us about some exciting work she's doing on gait and mobility improvement in Parkinson's using NVNS, as well as reduction in biomarkers. Then finally, Dr. Stotz will take us home by looking at how GammaCore, the physician-prescribed, patient-administered, non-drug NVNS treatment, prevents and treats migraines in minutes. For those of you, just a quick refresher, the vagus nerve, the 10th cranial nerve, and for those of us in integrative functional anti-aging medicine, we really see so many patients come in dysregulated with sympathetic dominance and essentially vagal insufficiency. They are not getting enough vagus nerve stimulation for the parasympathetic nervous system. So today we're only going to be talking about the non-invasive vagus nerve stimulation. There are other mechanisms, but today we'll confine ourselves to that. Just very quickly, the vagus nerve is a mixed bidirectional nerve, with 80% being afferent, sensory, and 20% efferent coming down from the brain. It contains three types of fibers. Large myelinated C fibers. Now, these affect the heart. And in the NVNS stimulation we'll be talking about, there is no effect on these large fibers. So there is no risk of cardiac issues. But what NVNS does affect are the small myelinated fibers, the B, and the small unmyelinated, the A fibers. So that's where the concentration will be. I'm sure you remember this from your days in training and the wandering power of the vagus nerve. It attenuates nociception, which is the perception of pain, reduces cortical spreading depression, which is this wave of depolarization, and has other brain modulation effects, also affecting neurotransmitters, which is very important. Cardiac, the C fibers, it can reduce the heart rate, blood pressure. It will affect, the vagus nerve affects bronchodilation, gluconeogenesis, has so many fibers coming from the gut and back to the gut in terms of GI motility, secretions, even satiety. And in the spleen, it's important for the detection and the regulation of systemic inflammation. So we'll be talking today about the use of a device called Gammacore. Now, this is a non-invasive vagus nerve stimulator that is held up to the neck. The treatments are usually in minutes. You'll learn more about that. But it is prescribed by a licensed practitioner, and the patient actually self-administers the treatment at home. Today, we will be talking about both on-label and off-label uses for this particular device. It is my pleasure to turn this over, the presentation over to Eric Liebler, who has really been one of the proponents and the stars in terms of non-invasive vagus nerve stimulation. He's got over 30 years of experience in neurology. He's a senior VP at Electrocore. He leads all of the medical affairs. He's an author of more than 50 papers. He's co-founded one of the companies that was involved in specialty pharmaceutical company. And he sits on the board of trustees of the American Brain Foundation. And he's been doing that for quite a long time. I think you will really enjoy his presentation. He's got some very exciting information to share with you about all things that the military are doing. So I'm going to turn this over to Eric.
Thank you, Mark. And now we will hopefully keep our fingers crossed and make sure the technology transfer is successful. And if I have been successful, you can all see my screen and hear me. And I see Mark nodding, so we can continue. So it's really exciting for me to have a chance to share with you what the military in the United States is doing with NVNS. Because in particular, as we go through this webinar today, we're going to talk first about what might be the benefits of VNS in healthy normals, or as the military likes to call them, maybe a little bit better than healthy normals. How can we enhance the cognition, performance, improve mood, decrease fatigue in people who are out there performing very stressful tasks, long mission cycles on an ongoing basis? They've invested over $5 million in this effort. And it's really moving closer and closer to fruition. So we're excited to give you a preview of some of the work that they've done. And what I'm going to share you is now in the public domain. So what we're going to talk about specifically is how do we help the person who's looking for a little bit better focus, energy, which many of us could use. How do they hit the bullseye? How can they perhaps enhance their performance? And we're not talking, we're not going to make someone run the 100 go from 10 seconds to 5 seconds, but maybe 10 seconds to 9 seconds, 0.8, things like that. By also decreasing fatigue or the perception of fatigue, by increasing mood and energy, and as well thinking about cognition and learning, whether that's in kind of embedding a new skill, such as observing and watching monitors, or some work that is pending right now, perhaps expediting language learning. So can we expedite or improve the ability of our people in the military to pick up a new language, such as Mandarin or Farsi? So first, you're going to hear a lot about these different mechanisms today. Dr. Tager talked a little bit about it. What I want to highlight is what you know. As integrative and functional specialists, you know that the vagus is a broad active nerve. It's the opposite of a drug. A drug is designed to do one thing and one thing well. My area is in neurological science and research. We would look for drugs and chemicals that had as tight a focus, so we would have as much on-target effect with little off-target activity, because off-target activity represented side effects that we did not want. In the case of VNS, you are asking self to treat self. And there are these 4 different areas where we have done and published substantial research, beginning up at 12 o'clock with the effect on pain. Now, that's not what the military is focused on. The military is looking at performance, activity, reaction times. So the 12 o'clock about nociceptive pain as well as 3 o'clock with cortical spreading depression, which Peter will talk about in terms of migraine, are not really what we're focusing on in terms of healthies. In healthies, we're looking to manage and modulate these neurotransmitters, provide a change or an enhancement of your inhibitory neurotransmitters like serotonin, noradrenaline, make sure that you don't have any excess glutamate so that you can kind of have that kind of happy, comfortable, energetic feeling, regardless of the amount of stress or sleep deprivation you may have had. And the same thing on the autonomic nervous system. If there are things during the day that increase your stress and decrease your capability, how can we mitigate against that? Who's this for? Well, it's for people like you. It's for people like my daughter who's in college. It's obviously being driven right now by activity within the military, as well as athletes who are looking for that slight difference that for them can mean the difference in how they place, whether that's a runner doing it enthusiastically on the weekend. I'm not positive we can make Usain Bolt faster. I don't think anyone can. But as you can see, whether that's the military or shift workers driving their trucks across the country, medical personnel, educators, students, enthusiasts, really, as this continues to come forward, we can all envision a number of settings where this might be valuable. So now we're going to go into the data. And this is a published paper, came out about a year ago. A second paper is under review right now, looking at what the Air Force was able to demonstrate in terms of can NVNS improve human cognition in a specific sleep-deprived process. Now, for me, working with the military has been really eye-opening. I did not have the opportunity to serve when I was younger. And so I go down to Herbert Field now, and they gave me this next little piece to help you understand what they're thinking about and who we're trying to serve here. So for me, this is exciting because it's very different. Today, I'm actually, coming to you live from Rochester, Minnesota, where the Mayo Clinic is initiating a study in long COVID. It's really exciting to be able to talk to people, for example, at Wright-Patterson Air Force Base, as well as Herbert Field. Why are they doing this? And here are the highlights. They call it the bottom line up front. Through the stimulation of the locus coeruleus, that's long been believed to be an effective fatigue countermeasure. Our question is, can NVNS enhance that cognitive performance during a long 34-hour period of wakefulness? The answer was we were superior to sham across all of our endpoints, and I'll show you that data. And our benefit lasted well more than 12 hours after stimulation, in theory, in that kind of the zero dark 30 after midnight hours, when performance should typically be at its worst. So I don't need to tell you this. You guys focus on these areas about why this is important more than my colleagues in the field of neurology. The side effects of missing sleep are extraordinarily broad. It affects your mood. It affects your activity. It affects your memory. It can make you anxious, agitated. It can affect your immune system. It can affect your gut, whether you keep feeding yourself, heart rate variability, all kind of some of the hallmarks of functional and integrative medicine that are so often overlooked by kind of the, let's call them the typical traditional medical specialist. In neurology, we like to diagnose and adios, move it along. On the right, you can see the issue inside the military. Over 65 to 70% of their operators and aviators are getting 6 hours or less, with many of them getting 4 hours or less, and they are consuming mind-boggling amounts of Red Bull or Monster energy drink. This is costing them effectiveness. They're having lower reaction times. They cannot multitask. They are not able to focus. What we're hoping to do is show that we can improve this. And that means they'll perform better watching the screens as a drone operator or as a flyer. So these are real practical things that is what the Air Force is in business to do to help protect our country. Here was the experimental paradigm. They wake up at 7 a.m. They then have to go the next 34 hours with no nap and no caffeine or any other medication. This is atypical. So this is very much a clinical setting because, as we mentioned on the last slide, they typically want to enjoy a great deal of coffee or energy drinks. They went in for their initial baseline work at 4 p.m., marked here as S1. And then they did their stimulation, only 2 sets of stims at 1900 or 7 p.m. and 7:30. And then you can tell this is a military study because they were able to make their subjects do a full battery of evaluations every 3 hours over the next 24 hours. So 9 separate evaluation sessions. What did they do? I'm not going to read all of these, but this is, kind of the things I don't work with these assessments. These are very specific military assessments. The Mackworth clock test, looking at vigilance, where you click a button. Some people have seen things like this, maybe in an eye doctor. The NBAC test, which is focused on working memory. This one's a little bit more like a memory test, like that you might use in Alzheimer's. In this case, it's a little bit more specific. They show them series of letters. Then the letters, when they come back, they have to recall whether they saw that. Psychomotor vigilance is seeing the light across a broad range of screens. And the MATB is a kind of integrative test where you put 4 different stimuli together in different quadrants. You can obviously see why that might be helpful in the military, where on average, a drone operator has 8 screens in front of them. And then finally, mood state. How are they doing throughout this day of an extended mission cycle? And now I'm going to show you about 4 slides of data. There's lots of little dots on here, and those are individual patients. What you can see is the blue always has less degradation in performance than the red. That is NVNS doing better than a sham treatment. And that's another nice benefit. This is a sham-controlled, randomized controlled trial. So you can see on the left, this is the overall composite activity. And you can see statistically significant improvement from 4 a.m. to 10 a.m., where people typically were having a 30 or 40% change from their baseline, their own individual baseline. Now they are suffering at the most a 10% degradation. On the right-hand side, you're looking at specific measurement of lights. You again see that benefit beginning at 7 a.m. and going all the way to 4 p.m. on day 2 of the study. Dial performance, not hard to imagine what that is. That's looking and reading correctly what's being shown to you on different dials, whether that's speed or altitude, oxygen, etc. This was also showing significant improvements in the kind of later time frame. On the overall system monitoring, you can see significance again from 7 a.m. out towards the end of the time frame. And now we move into the 2 final ones, which I split onto individual slides. First, the psychomotor vigilance task. That's the ability to kind of grab and see where these different activities are. This could be potentially beneficial in something like, seeing something on the side of a road and your peripheral vision. And the other thing to note is, where are all these individual dots? Each dot here represents a patient. And you can see those blue dots using GammaCore or NVNS are really clustered just right around the baseline of 0 or just below. All those red dots, you have some people who are suffering from about a 50% degradation in their capabilities at 4 or 7 a.m. And one would suspect that if you are performing better across all of your mission parameters, you're going to hopefully feel a little bit better. And this question, this mood questionnaire, again, look at the separation for those of you who can see the colors clear enough between blue and red. When you get down to -5, there's no longer anybody with NVNS who had that percent degradation. NVNS is clustered around baseline or -1. And that statistically significant improvement began at 4 a.m., about 12 hours after they entered the study, and continued all the way out to 1600 hours. That's meaning you're getting 12 hours of performance that is differentiated from what you would have had without treating with NVNS. So their conclusions: long-lasting benefit. 2 stimulations, benefit for more than 12 hours. Perform better across all of their different measurements. They feel less fatigued, more energetic, and the U.S. Air Force believes this is an effective treatment. And right now we're moving forward to look at deployment options. So with that, as you see, this is the Air Force Special Operations Command leading the effort in collaboration with the Air Force Research Labs in Ohio. Other areas like NASCAR have recently approached us and will probably be investigating our ability to help their drivers as well. So I thank you for your attention. We'll take some questions at the end, and I'm going to stop sharing and turn it back to Mark.
Great. Thank you, Eric. Let me share my screen here. I just want to also point out that a stimulation is a 2-minute period of time in which the device is connected to the patient. We're going to go across the pond where Allison Yarnell is sweltering a bit, but she has consented to keep her fan off for just a little bit of time. She completed her PhD in 2013 at Newcastle University. She is currently a clinical fellow. Let me just do a little something right here. There you go. An intermediate clinical fellow at the Translational and Clinical Research Institute in Newcastle University. Now, she also directs the research unit. She'll be talking about some very exciting research on Parkinson's, but we have to love this. She's an honorary consultant in older people's medicine at Newcastle upon Tyne hospitals. So they say it the way it is, older people's medicine. But she's got a great interest in cognitive decline and specifically in gaits and falls in people with Parkinson's. And she's published more than 100 articles. And she runs a specialist clinic for older adults with Parkinson's and complex health needs. So I'm going to turn this over to Dr. Yarnell. Let me just stop my sharing. There you go. And if you could just share your slides, Allison.
Brilliant. Hopefully you can see those now. And hopefully you can see my full slide. Unless I hear anything, I will presume that you are all seeing this. So thanks very much for the kind introduction, and thanks to Eric and Electrocore for the invitation to speak at this webinar today. So pardon the pun, but I'm going to walk you through some of the gait changes that we see in Parkinson's disease and how we're using an exciting new study, NVNS, to try and improve some of those measures. So these are my conflicts of interest. So just to say, Electrocore provided the devices free of charge for the study I'm going to tell you about, but they have no intellectual input into the study. So I'm going to start just about giving you a brief background about Parkinson's disease. I'm sure you're all aware of it. You all know people with it. And here are some of these photos of famous people who have the disorder. So it's common, and it's becoming more common. And in fact, it's the fastest growing neurological condition in the world. Here in the UK, we have around 145,000 people living with the disorder, and roughly that equivalents to around 1% of people aged over 60 affected, increasing up to 4% of people aged over 80. So a lot of the patients that I see in my clinic, and it increases with age. Historically, most of the research and a lot of the research has focused on these motor symptoms shown here, so tremor, rigidity, and bradykinesia. However, we know that other features such as gait impairments, shown here, with cognitive impairments, are common and significantly impair quality of life in the disorder. Gait issues are a cardinal feature, and I'm going to talk to you a bit more about how we know this. So what do we mean by when I say gait? And what I mean when I say gait is the way we walk. And this leads me on to why we're using NVNS and how we've come to discover this. Gait can be really thought of as a window into the brain, so an opportunity to look perhaps how the body and how the brain are functioning. Some people consider it's the sixth vital sign of health. And we know from research that changes such as a slower walking speed might reflect changes in your brain or body and indicate that further tests are needed. So, for example, it might indicate that you might have memory difficulties or that you're more likely to fall. And how do we measure gait? So Eric has visited us in Newcastle here in the UK and seen our gait laboratory. And here is shown our instrumented walkway here with someone walking on it. So our team, a few years ago now, have devised a comprehensive model of gait by studying gait in both healthy controls and in early stage Parkinson's disease patients, and selected these gait characteristics shown here that are sensitive to aging and pathology. And these can be reduced into 5 key domains for interpretation. So this man you see walking along here might look from just kind of eyeballing him that he's a healthy control, but in fact he is actually someone with the earlier stage Parkinson's disease with Hoehn-Yahr stage 1. And we can tell that certainly from identifying these more discrete characteristics. Much of the work that's been done on gait in Parkinson's has been led here in Newcastle by my colleague and mentor, Professor Lynn Rochester, and working also with Professor David Byrne. So you've seen from the previous slide that these instrumented walkways can capture gait, and also increasingly we're using wearable devices, often worn on the lower back. And these look at these spatio-temporal gait characteristics that reflect a typical gait cycle. And this is expressed as the mean number of steps. Some of these are shown here in this slide. So we know, for example, that gait speed is reduced even in early Parkinson's disease. And this results from a reduction in stride length, and it's compensated by an increase in cadence or an increased number of steps over time. And that's all very nice, but what we're really interested in and what leads us into the NVNS work is this gait variability. And this reflects stride to stride fluctuations in walking. And these are shown at the bottom here. So this is important because you can't consciously control for this. So meaning that unlike, for example, gait speed, you shouldn't get a placebo effect. And really to understand how we can treat gait disorders in Parkinson's, we need to understand the mechanistic underpinning. This is a bit of a busy slide. I've said that gait disturbance is a cardinal feature of Parkinson's. Most of you, I'm sure, will be aware that the mainstay of treatment for PD is dopaminergic therapy, so levodopa, dopamine agonists. And we know, although that they may be used to target gait impairments and they have some effect, significant gait impairments do remain and may be refractory to treatment. And this suggests that perhaps there's underlying other pathologies there that play non-dopaminergic. So this work here, this is a radar plot from our early work in people with early stage Parkinson's disease, so a mean disease duration of less than 6 months. And this plot on the left here shows that even at this early stage, there are significant differences or impairments in a number of the gait characteristics, so 12 of these 16 gait characteristics, which covers a global impairments in the number of domains. And this pattern was different when we divided those into different phenotypes. So not surprisingly, those who were a posture instability, gait difficulty phenotype were more impaired than those who were very much tremor dominant. What we did with this early stage Parkinson's disease patients was we went on to model gait progression over a 3-year period and compared this to our control group. What we found was that declines in step time variability and step length variability were significantly impaired and increased compared to controls. And I want you to remember these because this will come up again. And this is important because these impairments underpin and predict falls risk. And this is important for our NVNS work. So I've said that maybe some of this gait disturbance is underpinned by non-dopaminergic pathology. And we think here in Newcastle that acetylcholine or cholinergic dysfunction plays an important part. We know from imaging work from over in the US, from Nico Bonin and his group in Michigan, that he's shown from functional imaging that those who have a slower gait speed have significant reductions in cortical cholinergic innervation. We can also measure and monitor cholinergic dysfunction using a neurophysiological technique called short latency efferent inhibition, and this is demonstrated here. And this is thought to non-invasively assess an inhibitory circuit that's thought to be cholinergically mediated. We and others have shown that short latency afferent inhibition, or SAI, is significantly reduced in people with Parkinson's compared to controls and is an independent predictor of gait speed. Similarly, patients with Parkinson's disease and mild cognitive impairment, so some impairment in cognition that's a transitional state between normality and dementia, exhibited, again, less inhibition in SAI, highlighting that cholinergic dysfunction is an important and probably an early contributor to both gait and cognitive dysfunction in the disorder. How else, or what other evidence do we have that cholinergic dysfunction is important? Well, we've got structural imaging. So we know that the nucleus basalis of Minot, shown here, which is located within the cholinergic basal forebrain, provides major cortical cholinergic output to widespread areas in the cortex. And changes in this have been linked to cognitive changes both in Parkinson's and in aging. One of our PhD students recently completed her PhD, and she looked at nucleus basalis of Minot volumes and linked this to gait change over a 3-year period. And look what came out again. She found that lower or smaller NBM volumes predicted future disease-specific gait changes over 3 years. And taken together with this and on our other studies and our other research areas, these help strengthen the case for targeting the therapeutically targeting the cholinergic system to try and limit some of this PD gait progression. Well, if that's the case, how might we intervene? So some researchers have looked to intervene pharmacologically, and this is work from, again, British researchers, Emily Henderson and her colleagues down in Bristol in the southwest. And they've looked to target gait impairments with rivastigmine, which is a cholinesterase inhibitor, which increases the level of acetylcholine at a synaptic level. She undertook a study which took Parkinson's disease fallers and randomized them to either receive a placebo or the rivastigmine. And what they found was at the end of the treatment time, there were significant improvements in, look, there it is again, in this step time variability. And that was the primary outcome measure. But importantly and significantly, over time, there was a 45% reduction in falls rate. And she has started a phase 3 study. We're recruiting to it at the moment, and recruitment's probably going to complete in the next couple of months. What about what you've come to hear about? What about NVNS, or non-invasive vagus nerve stimulation? And we think here that this also may activate some cholinergic circuitry. You've seen from Dr. Drager earlier the NVNS device, the new Gamma Core device. This is the study we did using the older device a couple of years ago now. And we took 30 patients with Parkinson's disease. They underwent this comprehensive gait assessment using that instrumented walkway. They also had a number of other assessments. And then they were randomized to either the active or the sham treatment. They delivered a stimulation for 2 minutes to one side of the neck, and then they had repeat measures. And we really wanted to focus on these more dopamine-resistant gait characteristics. What did we find? Well, again, we found that this step time and step length variability improved in those who'd received the active treatment, although only step length variability actually reached significance. In the same edition of Movement Disorders Journal where this was published, this was work that was being done in parallel from a group in India. This was a slightly smaller study, so they just had 19 patients with Parkinson's, and this was an open label study. So again, they had a number of measures of gait that they assessed pre and post treatment, but they gave 2 stimulations. And what they found was that a number of these spatiotemporal gait characteristics improved after the active treatment, in addition to some measures of freezing of gait, which is frequent in Parkinson's, especially as the disease progresses. They then took this forward to a longitudinal study. So this was a double-blind randomized crossover study whereby patients with Parkinson's and with this freezing of gait were randomized to either, again, the active or the sham treatment. They were then asked to deliver 6 2-minute stimulations of NBNS per day. Before this time, they underwent a number of assessments. They were reassessed at a month, had a month washout, and then switched treatments. And you'll see here from these graphs that there were significant improvements in some of the pace gait domains, so in gait speed and step length, in addition to some of the rhythm measures, so stance time. However, different to what we found in our work, there was no changes in variability, in gait variability, and there was no carryover effect after the washout. That's all very nice, but how do we think that vagus nerve stimulation might work in Parkinson's? And for any of those of you that are interested, we had a review published on this just last year. So we've already heard from Dr. Tager earlier that the afferent vagal pathway is synapses at the nucleus tractus solitarius, shown here. We know that it then, as Eric has just talked about, this then projects to this locus coeruleus, and this causes upregulation of norepinephrine. What we think happens is that this then projects to this cholinergic nucleus basalis of Minart, and this may cause upregulation of acetylcholine. What we know from subjects, from healthy volunteers using functional imaging, so functional MRI imaging, is that after these healthy volunteers received NVNS stimulation to the left side of the neck, there was increases in this blood oxygen level dependent activity or responses in a number of areas that receive cholinergic innervation, including the caudate, the thalamus, dorsolateral prefrontal cortex, and the somatosensory cortex. And there were also reductions in bulb responses in limbic regions. Similarly, there have been studies in animal models, and specifically in rat models, have shown that after lesioning the locus coeruleus norepinephrine and the substantia nigra dopaminergic pathways, that this causes a locomotor deficit, and this can be reversed by vagus nerve stimulation, possibly through an effect of reduction in inflammatory pathways via nicotinic acetylcholine receptors. You've also already heard about the efferent connections of the vagus nerve. So the pedunculopontine nucleus, or the PPN, is another core area in cholinergic activity in the brain. And this and the dorsal motor nucleus of vagus are key players in the central cholinergic and the efferent vagal pathways. You've heard before that the vagus nerves innervates the lungs and the heart and regulates autonomic function. And it may also stimulate the splenic nerve through this vagosympathetic interaction involving acetylcholine and releasing norepinephrine to reduce some of these pro-inflammatory cytokines. So with this background, I was really pleased to competitively receive funding from the Dunhill Medical Trust and Parkinson's UK to take forward this work into a multi-dose study. And this is this rather contrived Advancing PD acronym. So we want to really ascertain whether the effect of NVNS on gait is sustained and enhanced when it's been delivered repeatedly, and whether this effect is sustained over time. So we thankfully and pleasingly started recruiting patients in January time. We're looking overall to recruit 40 participants with Parkinson's disease. They're coming in at baseline and they're having a number of demographic measures taken. We're testing autonomic function, heart rate variability, lying standing blood pressure. Interestingly, in terms of what Eric's just talked about, they're having computerized cognitive assessments. We're taking blood samples from them. And key, we're looking at an instrumented walkway gait measurements and also measuring gait with body-worn sensors. These participants are then being instructed how to deliver NVNS under supervision. And they're then going away and delivering this 2 stimulations twice a day over 12 weeks with follow-up, and we're collecting falls data as well. After 12 weeks, they're coming back and having everything repeated. We take the devices away, and then we're asking them to come back at 24 weeks to see whether there's any carryover effect. These are our inclusion and exclusion criteria. Sadly for me, we're because of the lack of safety data in older patients, many of the patients I see in my clinic actually are not taking part in the study, but really we're looking for patients with mild to moderate disease. They're able to walk, they don't have dementia, they don't have these other exclusions or contraindications that would exclude them from taking part in the study. How are we getting on so far? Well, we're relatively pleased with our recruitment to date. So we've consented 15. Sadly, we've not been able to recruit 4 of these due to various reasons, but hoping that some of these will be able to join back in the study. There have been 2 patients so far that have dropped out, one for a totally unrelated family reason, and another who felt that it was making his gait worse, or his Parkinson's worse, and he stopped using the device. So what have you learned from this talk, if anything at all? Maybe what I haven't been into is that with Parkinson's disease now, we very much have improvements in managing the motor symptoms. So actually we get this right shift of the curve and people living for longer with other complications associated with Parkinson's disease, including gait dysfunction. Gait impairments are a cardinal feature of the disorder. They're often there at diagnosis, and they progress as the disease progresses. And this is probably an interaction of both PD-specific and age-related changes. I hope I've shown you and convinced you that we think the cholinergic system is important, and cholinergic dysfunction directly contributes to gait impairments. And by researching this and researching areas to try and maximise and improve cholinergic function, we hope that we can help deliver some new and rational therapies to help treat the disorder and help with lots of patients and reduce drug burden. So thank you very much for listening. And this is just my group, co-investigators and funders here.
Great. Let's see. Thank you so much, Allison. That was really, really interesting. And we look forward to learning more about your research and following it and your study on advancing PD. We're going to turn now to, previously, we've really talked about off-label indications for the Gammacore device. Now we're going to switch our focus and get back on label, as Dr. Peter Stotts talks about migraine specifically. He was the founder of the Division of Pain Management at Hopkins, the director for 10 years. He's internationally regarded. He is a past president of NAMS, the North American Neuromodulation Society, the American Society of Interventional Pain, and the World Institute of Pain. So I would go ahead now, Peter, if you could, okay, we're sharing your screen. Take it away, please.
Thanks, Mark. Before you jump off, can you see my screen now?
Yes, we can.
Okay, great. Thanks so much. So it's a real pleasure to be with you guys today, and thank you very much. It's really hard to follow the 2 previous speakers who are talking about some of the most cutting edge work going on today in medicine and general health and wellness. I do want to just mention that what I'm going to talk about is on label, what's been evaluated by the FDA, and it would be considered on label with the European Union as well. But we're going to talk primarily about migraine for the next few minutes. In fact, there are FDA clearances for general migraine, prevention of migraine, acute treatment of migraine, adolescent migraine, acute treatment of episodic cluster headache, prevention of cluster headache, treatment of paroxysmal hemicrania, hemicrania continuum, among the headache disorders that are out there. You will also note there that on the bottom of this slide, there's a breakthrough designation with a PTSD. That is not the same as an FDA approval or clearance, but rather that the FDA has evaluated early work in another area that's so relevant and has some clinical overlap and mechanistic overlap with what we're going to talk about today. We also have an emergency use authorization in difficulty breathing due to COVID. In Europe, the EU indications are as follows. There's a primary headache indication, airway reactivity, GI disorders, anxiety, and depression, and in fact, epilepsy. So this has been approved in Europe or used in Europe since about 2011. So we have some significant experience with this therapy that I'd like to discuss. Now, our 2 previous speakers have talked about making a good brain better, our super warriors, super duper warriors, and helping patients with a neurodegenerative disorder. I'm going to talk about migraines, and migraines are probably the 3rd most prevalent disease illness out there today. It is the 6th most disabling illness. About 14% of the population have migraines, or 1 in 4 households, and this affects about 18% of women and closer to 6% of men. But again, you can see that this is really a tremendous problem throughout the world, with the costs that are really astronomical on costs. We've attempted to get around this with drugs, biofeedback, and this is yet another avenue. You can see this picture of this brain here, and I like to think of the brain as a chemical organ, but more importantly, it is also an electrical organ. And I hearken back to the days of stimulating a little frog leg when you were in grade school and you could see the frog leg jump. That's because we are controlled by electricity. And this is something that's been really forgotten by modern medicine. We started working on this really almost 20 years ago, 18 years ago now. We were working on airway reactivity. And while we were studying this, we realized that patients with headaches were getting better. And subsequently, we've now got, as I've mentioned, 8 FDA cleared indications, 7 RCTs, 15 IITs, 30 mechanism of action papers, and 40 clinical papers. Hard to summarize, of course, within 15 minutes, and happy to take this offline with anybody. But suffice it to say, this is probably one of the most well-studied areas out there in primary headache problems. Unlike some of the new therapies that are coming up, where you may have 1 or 2 studies out there, the amount of research being spent on assessing primary headache is really phenomenal. It is now considered first line for cluster, and for my European friends, it is covered by NICE because of its not only efficacy, but cost dominance, demonstrating a significant savings of over 450 British pounds when patients with cluster utilize the therapy in the system that they've set up there. So this is, in fact, a really effective therapy. And I would also add in that in the United States, the best practices, Congress mandated the best practices task force to take a look at this, and it was given a very favorable review. Now, I like to take a look at data, just like Eric presented data and Dr. Yarnell presented some very interesting data. When I started to hear about people getting better with vagus nerve stimulation, it was important for us to do some clinical work on assessing why that is. And Michael Oshinsky, who's now, I think, at NINDS, created a model of migraine, really an allodynic model, where he created an inflammatory soup. And then when that animal is subjected to nitroglycerin, much like humans who are subjected to nitroglycerin, they could experience more behaviors consistent with migraine. In this setting, was an allodynic model. But interestingly, there was an increasing level of glutamate, one of the primary excitatory neurotransmitters in the brain. And you could see that this would be increasing over time, and that's the orange bar here. But when the vagus nerve stimulation was used in this animal model, it could block not only allodynia, which I've not shown you here, but also that correlated directly with a reduction in the glutamate that you see at time 90 minutes here. That this actually reduced glutamate and neurotransmitter production. The group up at Harvard wanted to take a look at cortical spreading depressions, looked at the frequency of cortical spreading depressions, the threshold of cortical spreading depressions, and even the speed of cortical spreading depressions. Now, I bring up both glutamate and these cortical spreading depressions to give you an idea of the broad mechanistic thoughts about how this works. The cortical spreading depressions, in fact, lead to development of pro-inflammatory cytokines. But it also lets you start to think about, well, maybe this is how this would work in a patient with aura, where you have a wave of electrical activity known to go across the brain. When clinically your patients will say, well, I see some aura out there, probably an ocular cortical spreading depression, or I feel something in my arm, and then it goes up to my shoulder, and then it goes into my mouth. And people can then say, I'm feeling something. And that's probably a wave of extra electrical activity that's occurring that was improved almost immediately in both hemispheres with unilateral non-invasive vagus nerve stimulation. So again, a very strong mechanistic rationale. And also in this Harvard model, the pro-inflammatory cytokines. Now, this group is very familiar with cytokines and inflammation. These 2 pro-inflammatory cytokines, IL-1 beta and TNF alpha, are really known to be the mediators of inflammation. And in these models with vagus nerve stimulation, one could block the production of IL-1 beta and TNF alpha in these inflammatory models of cortical spreading depression. So now what have we talked about? We've talked about glutamate. We've talked about cortical spreading depressions. We've talked about inflammation. And Eric had a picture of this slide a few moments ago, but just to show that the advantage of electrical treatment is that there can be very profound effects on multiple systems with multiple mechanisms of action. And that is really one of the key take-home messages for us today. Now, there have been a number of studies out there, acute study, I'll just mention the Presto study, but this is just one of many studies out there. The Presto study was done in Italy at close to 250 patients looking at this group here. And there was an improvement in pain freedom in the group who had vagus nerve stimulation all within the first 2 hours. Highly statistically significant when looked at a repeated measures test, or effectively area under the curve, looking at within 2 hours, can we get rid of your first, your attack during your first attack? Some of the things we use in medicine is what's your 50% response rate? And you could see that it was almost 50% or 47.6% of the patients who received the active device compared to the sham device had pain relief at 120 minutes. Again, highly statistically significant. Rescue of medication use. We're all worried about how much medicines our patients are using, both attacks that don't require use and the patients who don't require use. Again, highly statistically significant improvement in vagus nerve stimulation compared to sham. So this, in summary, is an effective therapy for acute treatment of migraine in both reduction of pain, decreasing the severity of the attack, data I've not shown you, but also the amount of medication used. Now, there have been a number of studies on prevention. Acute's great. It's great to have a single device that can help you with your an attack, but can we keep them from coming? And a number of studies have been done as far back as really 2016. These data has been out there, but the most recent study was out in 2022 in our what's called our Premium 2 trial. Now, this was a difficult trial to do, the Premium 2 trial, because there was a little pandemic that hit called COVID that was really well known to cause problems with inflammation and headaches. And we really felt like it would be so difficult to complete this study under the confines of COVID. We cut it short at 113 patients, a little less than close to a third of what we had planned on for the clinical trial. But nonetheless, we were able to find some very interesting findings in the study. I'm going to start with the Premium 1 trial, just very briefly, well-matched control patients. And we found a significant reduction in the number of migraine days and the 50% responder rate. We found a reduction in headache days. It's slightly different than migraine days, but headache days, and the number of days in which a patient needed to use a medication of some sort or another. The Premium 2 study was more recently published in January. A very interesting study looking at the device, slightly some small differences in study design, but you can see a reduction in number of migraine days of about 3 versus about 2.29. So really significantly improvement in the number of migraine days. One of the most effective things that we've seen to date is I've spent a fair amount of time talking about aura today with you and why that clinical rationale, a patient with aura might have these cortical spreading depressions. And mechanistically, we've shown in an animal model that we can affect cortical spreading depression. When we pull out this population of patients who have aura, you could decrease the number of headache days about 5.5 days. I don't actually know of another therapy out there that's quite that effective in decreasing the number of headache days that are out there. So again, highly effective and statistically significant, even with an abbreviated study with a fraction of the number of patients in the study that we had initially planned. So This is somewhat of a summary slide of some of the work that's been done and the work that we're going to continue to do in other areas. We've been talking today about our super soldiers. We've been talking about Parkinson's disease, but there are a number of other areas that are really exciting and interesting as well. Opioid use disorder, post-traumatic stress disorder, all have overlapping and similar mechanisms to some of the things that we've talked about. We've invested in well over 1,000 patients, as you've seen here, in clinical trials of various types of migraine and cluster patients, leading to a number of FDA clearances here. And again, it's important to note that this has been subjected to the rigor of the FDA with our primary headache disorders, as you see here, and I've listed in the IFU. The other areas are continuing to be researched, but I thought it would be of interest to you to understand the direction of the field of vagus nerve stimulation and how this simple little structure in the cervical spine that goes up to the brain with tracts from the nucleus tractus solitarius to the various other areas in the brain that you've heard about today can have such a profound effect on so many different disorders. I would also just submit that back in 2016, it was really noted that we had an opioid crisis, and Congress mandated that we do something about it. And they mandated the best practices task force that was published in 2019. And within this guideline, they talked about some of the papers I spoke with you today as an alternative to opioids for patients with cluster and migraine, indicating the level 1 studies that are out there. So with that, I want to conclude to say that there's a very strong mechanistic rationale of why we're doing what we're doing. We're not just throwing darts at this. We've followed the science and followed the clinical implications. There are multiple basic science protocols, many RCTs out there, CE mark in Europe also. NICE has endorsed this for cluster headache as it's effective and cost dominant. And this has been listed in the best practices pain task force. So with that, I will turn it back to our fearless leader, Dr. Tager, and look forward to answering any questions.
Okay, great. Thank you, Peter. Let me just share my screen here. Can you all see my screen? Hopefully, yes. So I'm going to encourage you, those of you who want to learn more about specifically the device gammaCore, to visit electrocore.com or to call this number, 888-903-2673. And I also, there you go. I also want to encourage you to join the Vagus Nerve Society, vnsociety.org. It's multidisciplinary, global, it's a nonprofit. You'll find a lot of great information and training materials there, and more as we build it out. And again, it is no fee from now on. So I'd like to thank all of you for attending and enjoy the rest of your day.
Thanks, everyone. Bye.
Thank you. Thank you, Dr. Yarnell. Thank you, Dr. Tager. Thank you, Dr. Faber.